Okay, so our screen is ready for our slideshow. All right, so this is our care coordinator and all else who are in attendance here, FAQs with updates. And just we know that our care coordinators are currently not using our Harmony data system. That is being used currently by our PCS administrators. For these reasons and many others, being as we have new programs and new options for people, questions and answers can change over time as we kind of grow and learn together. When care coordinators are working within Harmony, the processes and expectations will be a little bit different. As we get information, we'll of course share it in training. There'll be lots of training about Harmony. Typically, we get a lot of questions about Harmony during these sessions. We can certainly answer those over time. When care coordinators are in Harmony, there'll be more training about how to work with Harmony. So these are current processes that we'll have happening now for care coordinators, okay? You can go ahead and download your handouts in the webinar. We will send them to you in an email, so don't stress out if you can't get them or the device just doesn't seem to work for that. YouTube channel, we'll put the recording up, so if you want to review it later, or you can send the link to your colleagues who would like to review it after the session, no problem with that. This is not a care coordinator CEH session. This is just requirements for care coordination. We're running special CEH sessions that are topics of interest to care coordinators to enhance your practice. We're actually having a wonderful one tomorrow, so you might want to check the training website if you need CEH or if you're available to learn at a CEH webinar tomorrow. Everybody is welcome to attend this webinar today. Even though our registration said care coordinators or PCS admins, we just wanted you to choose one or the other. We can kind of tell by your email address which one you are, but we like to know just for our own data. So welcome to you all who are joining us here. There's a limited pilot group of care coordinators working in Harmony. Some of our care coordinators also have read-only access. That just means that they can see Harmony, but they cannot, make any changes in it. We are working on, meaning SDS, we're working on getting feedback and updates to our Harmony system through this kind of feedback loop, if you will, with our care coordinators. It's a long process. We do want to get it right. At this time, you will be submitting documents and packets via DSM, and there will be additional training. And when you start to use training, start to use Harmony, there'll be lots more training. So stay tuned for those things. So let's look at some big picture information. We usually get a lot of questions about, how does this fit in with the big picture? We did put some of those things into your handouts, so we'll take a look at those briefly here. Just give me 1 second to get them ready for you. Let me get them up on my screen. And again, this is just kind of information over time that we've collected to try to show us as providers of or knowing about all services what this kind of looks like. So I put together, we put together a sheet that just tries to portray long-term services and supports overall. We don't have to review the entire thing, but the helpfulness of this, I believe, will be the columns, the vertical columns, where you can see what are the choices that people have for Alaska Medicaid long-term services and supports, personal care, CFC, and I'll answer your question about CFC in just a second, and the ALI waiver, Alaskans Living Independently, APDD, CCMC, ISW, and IDD. So this chart doesn't attempt to show every detail about every service combination and every eligibility. It's just kind of an overview of what we have, okay? And then we have the different attributes of the choices, if you will, the PCS, CFC, and the waivers. What type of level of care, whether a person would need to be on the registry, DD registry. IMD means Institution for Mental Disease, and that is a behavioral health facility level of care. So we do have updated FAQs about that. So for CFC to help this population, which is, we don't know how many people will be accessing CFC through this kind of level of care, but we will review the questions about it. Okay, then we've got our care coordination. The different nuances with care coordination, the application, annual plan, and monthly contacts per the support plan being under targeted case management for only CFC, and then the application and annual support plan being targeted case management for the waivers, and the monthly contacts being just waiver care coordination. All right, so we do have that in our FAQs. ADLs and IADLs, and then the different services. So we don't really have to review the whole chart, but it does have the basic limitations here per age. As you can see, there's PCS, which is simply ADLs and IADLs, PCS only, doesn't include other things. CFC, another type of option for people. A person must meet level of care for a facility. They would, if a person wanted to have a personal emergency response system, it is only offered under CFC. And then the ALI waiver and APDD waiver are separate. Okay. So that is just an overview chart that is hoping to show you, kind of like the big picture of our services and supports, which we're kind of generically calling long-term services and supports through Medicaid. Okay, so I'm going to freeze on that screen and I will put that away. I did put that into your handouts. So you can check that out when you are ready to take more detailed look at it. It shouldn't be super huge surprises there, just because we do get many questions about how does this fit in with everything else. We're trying to portray how it fits in with everything else. This one here is just a reference chart for actually 3 of them on one page. Up at the top, the first one is the eligibility process. So for your understanding about eligibility and application, the person applies for Medicaid in all cases. Okay, for PCS, they apply at the agency. The question we did get questions about 300% eligible only for ALI. Okay. Does a person have to go through the ADRC? We have an X for the ones that are required. STAR coordinator, their role here. Wait list getting drawn from the DD registry. Okay, sort of new information for our ISW. A person will receive a letter inviting them to apply. So we're kind of going through the process of working with people who are ending the grant services and starting ISW. So trying to get responses from people who are interested to apply. Care coordinator and application. The middle chart here is really just about what the PCS agency does for PCS only. Okay, I get a lot of questions about that. What is the difference? So this is not for a care coordinator, but for PCS only. Again, a general understanding of roles and situation, how it gets situated with everything else. And then the application packets for a care coordinator to submit to SDS, just an application packet, okay? We do get a lot of questions about those, but it can help you as a quick reference for when you're applying. Okay, so I am going to freeze on that screen, and I'm going to put that one away. And we've reviewed our big picture information. So now I would like to move forward with our FAQs. And let me restart my slideshow so that we can see that. All right, so now you can see our FAQs. There are updates. We put them in red. And if we, of course, don't get a question that you have in your mind, of course, we'd be more than happy to receive that question and respond to it in our questions area. And you may see responses from Sina, maybe from me, Cassandra, Delight, or David. So thanks to all of you for being here to help us with questions and answers. Does the plan of care have a different name? It is now known as the Person-Centered Plan, so Person-Centered Support Plan, or perhaps just Support Plan for short. Same as a plan of care. Care coordination services are reimbursed a little differently now. Basically, the application for all waiver types is moved under what we call targeted case management, including application for ISW and IDD, which is not a separate application form. It continues to be, as it has been, the collection of documents for ICAP assessment to apply for ISW or IDD, but it is a service that can be billed. Application, back in the day, used to be called screening. Same thing, application form, initial application, one-time initial application can be billed under targeted case management. The annual support plan is now targeted case management, different code. Ongoing care coordination for only CFC is also targeted case management. Talk about what that is. I'm going backwards, meant to go forward. Ongoing care coordination for the waivers continues to be a waiver service and is billed under waiver Medicaid. ISW monthly ongoing care coordination does have a different code. It is a new waiver, so it has a new code. It's a code, okay? It has a new code, but not anything has changed since it was invented. In that sense, it's new. It was created, I should say. Okay. So why have we made this change? The change was made in response to a requirement from our legislature to save Alaska's Medicaid money by realigning services under categories of Medicaid that were relevant to that service. So waiver Medicaid saves a little bit of money. Regular Medicaid pays out some money. When it comes to Community First Choice, the reimbursement to Alaska for Community First Choice, as it is for all other states that choose to implement it, is 56% as opposed to 50% for the waivers. So states love Community First Choice because they can draw down a little bit more funding for all the services that are done for Community First Choice to help with sustaining the programs. You can see current rates of reimbursement on our cost survey page. And we can certainly click on it here and we'll see if it takes us there. It may not. It might just not want me to do any changes like that right now. I can go there in a different way. All right, let's open that page. So that page looks like this, so everybody knows. Looks like this. Payment rates and cost survey. So if we go down to about the middle, we'll find our current rate sheets. Okay. So if we look at the waiver one, this says waiver service rates, CFC, PCS, and waiver service rates. We're just talking about care coordination here. And right in the middle, you can see that it says care coordination monthly and the waivers that it's for. Okay. You can see the rate. You can see the code. Okay, the billing code. That is for waiver. So if we go back, whoops, let me pick up my tool here. We go back, there's another rate sheet right underneath it, targeted case management. So if we click on that one, you can see that targeted case management consists of application for a waiver or CFC, and it's got the service rate and the code. It's got the support plan, the first one, and then the annual support plan for any waiver or CFC. There's the rate and the code. And then it has case management, which is the monthly rate for monthly care coordination / case management for a person who has only a CFC plan. Nothing else, no waiver, just CFC with its limited set of services. So that is where you can see that information. I'm going to freeze on my screen and we'll go back to our slideshow. This takes me a couple of clicks to get back there. So, okay. So far, so good. Don't forget to put your questions in as they come to your mind. Be more than happy to answer them. Okay, so a CFC only plan is available for people who have Medicaid who meet a level of care for a facility. The person must be under 21, specifically age 6 to 21, or over 65 if they're going to come in under the IMD level of care only. Okay, so only for this one, right? IMD level of care, do we have the restrictions for the population's age? Okay, other than that, there is not the restriction for their age if they meet level of care for a facility. Question says, will all initial ALI applications be billed under CFC? The answer is yes. How do you refer someone to the IMD CFC? Well, we have that in our FAQs, so we'll get to that real soon. Okay. A CFC only plan contains these available services. A person must have a care coordinator, of course. So they have the care coordinator who provides targeted case management, application, annual plan, and ongoing care coordination. Okay. So the person may also have personal care services, which are called CFC PCS when they're in a CFC plan. But they are the personal care services that we are familiar with, hands-on help with ADLs and IADLs. Skills building is a service that a person may choose through CFC. It's help to gain skills, to be more independent, or to maintain skills, or to acquire skills, to be more dependent in an ADL or an IADL that the person chooses. The agency, PCS agency staff, hands-on staff will receive special training in order to be able to do that. And it does have a limit. It is limited to 3% of the total time authorized for PCS and up to 3 continuous months per lifetime of the person. CFC does not, the question says, I thought all CFC has to have a waiver like ALI. A person can have a waiver and CFC, just like they can have a waiver and PCS, or they still can have that if they choose to do so. But they do not have to have a waiver. They can have only CFC if that is the person's choice. Okay. Supervision and queuing. A person may be eligible for supervision and queuing if found in their CAT assessment. It is help to perform by themselves an ADL or IADL with the proximity of staff who cues the person to complete it. It's not hands-on help. It's cueing the person to do it on their own. It does have a limit. 3 hours per week or 6 hours a week, depending on their CAT score for cognition and behavior. Personal emergency response system, that is a communication system that is installed by the PERS provider so that they can summon help at home. That is not different. The big difference with it is that it is available in CFC. So if a person wants a PERS, they have to have CFC, whether they have a waiver or not, okay? And then optional training resources to manage your own staff. Training has produced a guide for the client called Your PCA and You. A care coordinator can share that with their client, as well as a PCS agency administrator or other responsible staff at the PCS agency, and they can review that document with their client and or their representative who may want to learn more about managing their own staff. I did put a copy of that into your handouts, so you can look at that when you have time. We can review it if you want, but that would be later after we're done with FAQs. Okay. Question says, if a PCS renewal comes up first, does the agency or the service agency need to submit the plan? It was stated that the plans were going to line up, but the portal and Harmony does not show this matching up. Okay, we do have that in our FAQs. If the person has CFC, meaning if they have a waiver and CFC, then the care coordinator will submit the renewal for both onto they'll submit that using one document. Okay, the PCS agency does not submit for renewal of just the CFC PCS in that case. The care coordinator does it. Okay. Okay. Is the person required to have all the CFC services? No, they can choose which ones to request, but for the care coordinator, they need to have a care coordinator. If a person has an IDD waiver and PCS, do they have to have CFC? No, a person who previously had PCS and a waiver, no matter what type of waiver it was, these individuals were auto-enrolled into CFC. So if a person wants to, if they weren't auto-enrolled in CFC and they're like a new applicant for PCS and they have the IDD waiver or any other, they could apply for PCS separately. Okay, but auto-enrollment has occurred for individuals who were combo clients, if you will, on October 1. Okay, people got letters to possibly opt out should they not wish to be auto-enrolled. Most people who were already combo clients, if you will, had PCS and a waiver, were auto-enrolled in CFC. So a person who has that is auto-enrolled in CFC, questions come in, my client has a waiver and had PCS2 and was auto-enrolled, doesn't want to keep any of the other CFC services except personal care services. Shouldn't he just opt out and keep just PCS? Okay, auto-enrollment and its opt-out period has ended. So it's not a matter of just opting out of CFC. The people who got the letters and opted out are all taken care of, okay? If a person at the current time wants to opt out of CFC, they are choosing to discontinue CFC. A care coordinator could submit the amendment form for CFC, which would remove CFC PCS services. So if the person wants PCS only, they would need to reapply. So they are removing all of the services, meaning CFC, PCS included. They will apply through, they would need to reapply for PCS only by applying through a PCS agency. The person may need a new assessment, and if that is true, then services may be awarded at different levels than previously based on that new assessment. So if they're opting out, they're discontinuing CFC and the PCS services in it, a person just doesn't revert back to PCS at the present time. So that is how they opt out. It really isn't opting out at this time. It's canceling their CFC and reapplying for PCS only. Okay. If a person only has PCS along with their ALI waiver, here's a question. How do we fill in the boxes on the new support plan? It seems like a repeat of PCS services added as it is now. Do we just repeat the info in the next box? Okay. If a person opted out or is a new applicant and choosing only PCS services and has a waiver, then the PCS application and reapplication for just those services is done by the PCS agency. If they're enrolled in CFC, then the care coordinator does all that. Okay. Not many people opted out during the letter period of an option to opt out. Probably less than 10 people opted out. So unless you have somebody who's a new applicant for, PCS services separately and they don't want CFC, they're starting PCS services along with a waiver, then you probably have a CFC client. They did not opt out, so how do we fill it out? The new support plan, yes, you would summarize the PCS services in the boxes you identified. So yes, it would be like a repeat. You would summarize them in those boxes so that we understand that the person wants to continue those services. Okay, the person gets an annual assessment, and the services can be continued or request to be amended in ways that we'll talk about in a little bit. Okay, so what's care coordination for CFC only? What does that look like? Question says, so we just put NA in the purse, etc. boxes. If the person does not want a purse, then that is true. Okay, you just fill out the form telling SDS what the person wants and what they don't want by using NA. Okay. A CFC only plan means that the person has some or all of the CFC services and they do not have any additional home and community-based waiver service. They don't have a waiver, only CFC. So what the care coordinator does is perform the monthly care coordination at the targeted case manager monthly rate. The frequency of the face-to-face visits is portrayed in the support plan, which is subject to review and approval, like any other support plan. Create the application and the annual plan, CFC amendments, and travel requests for PCS, like if the person had a PCS care while they're traveling within the United States, you would submit that travel request. You would perform all activities of care coordination as seen in the regulation and conditions of participation. And you would follow the approved support plan for face-to-face visits. And those are requested by the client. The client kind of identifies that, and it gets approved in the plan. That's all in the COPS for care coordination or targeted case management. Okay. Question says, I have an ALI client who just received their level of care. Personal care services was not requested at the time of the assessment, but she scored for PCS on the CAT. I would guess that a CFC amendment needs to be submitted. Yes, a CFC amendment. How would it be worded to generate the CFC PCS SLA, service level authorization? We'll have examples for you in a bit. Okay, if someone is only on PCS and then gets on a waiver or vice versa, will they automatically be put into CFC? That is a good question. I would probably ask David to take a look at that one. Can you give examples of what a CFC and waiver plan would or could look like for a consumer? Why would they have both? Because the person may have a waiver and they may want to have CFC personal care services at home, and they may want to have the skills building. They may have supervision and queuing. Okay. Why would they have both? The person would be eligible for and wish to receive those services, is my best answer. CFC does not apply when a person has out-of-home residential, by the way. If they live in a group home, residential supported living home, family hab home, that duplicates anything that would be found in CFC. CFC is a lot like PCS. Okay. The question says, what's a good way to explain to somebody that it's okay to stay on CFC without consequence? The couple families have questions about PCS providers being paid their rate of pay. They feel the CFC will decrease the hours of PCS. My best example here is you could certainly use any materials we provide to you, but I would encourage the family to know that they receive the same level of service through CFC as they did with PCS, and the reimbursement rates are the same. So it doesn't affect the rate of pay of the provider. It doesn't have to do with that. The provider's payment rate there's nothing has changed about regulatory requirements for those. Of course, from our level, we don't really get into that because that's the business practices of that particular provider, but there's nothing different about that. In fact, the skills building rate is a little higher if they wanted to pursue some skills building of reimbursement. And then supervision and queuing is a new service they could get. And if they wanted to have a personal emergency response system, they would have to have CFC. So those are some things that you can probably say. You could tell the person, you could suggest to the person that, hey, if you quit CFC, you'll have to apply for PCS and you may have a new assessment, which may say that you need more services or less, depending on that. Okay, so it could be either or. CFC is not involved with transportation. No. CFC, no, it's not a transportation. Transportation's not in CFC. Personal care services are in CFC. Supervision and queuing, skills building, and personal emergency response system. All right. If a person has an initial and doesn't meet level of care for the waiver, but they would meet CFC, will they be auto-enrolled in CFC only, or would we need to resubmit? A person has to meet level of care for the waiver in order to get CFC. If they don't meet level of care for the waiver, they could apply for PCS only. PCS only does not require level of care for a facility. That's my best answer to that. I'm looking at a question. I'm going to mark this one. Let's see here. Just taking a second to decide who to send it to. Getting lots of questions coming in. Okay. I think I'll assign it to myself. Let's see here. For the travel request PCA, we have to have the approval before they leave. It's my understanding that care coordinators do theirs after the travel. If this is true, how will the PCA agency be able to bill, or have the regs changed for? Nothing has changed for CFC. The care coordinator needs to do the travel request according to the instructions on the form. It's going to happen. It's not like an amendment. It's not like a waiver amendment. It's travel for PCS staff to do that. Okay, we can look at it. If at waiver application time they wanted an assisted living home and no CFC box was marked, now at level of care and plan of care time they have met with the PCS agency, other than the box not being marked that did the CFC application and PCI, okay, can PCS just be added to the plan of care? I think I'm going to send that one to David. Maybe help me out with that one. If CFC,
hey, Kara, it's Sina.
Okay, go ahead.
I could. It's cool to send that to David. I can give a little bit on there.
Okay.
So at this transition time, when we have waiver apps come in, and we still have them, I just answered this question for care coordinator. You don't really know at application time what's going to happen. Lots of things change between the time you put it in the application and the time you get level of care back. They change for the family. They change for all sorts of reasons. It's okay. If the CFC box was not checked, it's all right. Just go ahead and put in the amendment to say, hey, I want this assessment, or this person wants to consider CFC PCS. So community first choice, PCS services, and we'll just review the most likely, just review the most recent assessment. And when you do that amendment, you want to make sure you tell us which PCS agency. Okay. All right. So you wouldn't want to just add it to the plan. No, you have to make an application. And so in the meantime, you're going to do an application. You can use the one that you already turned in. Okay, and the one that you already turned in, and just say we're just looking at them, because without the application, they're not going to create the SLA chart. So if you just added it to the plan, it's just not going to work. You have to put the application in. And really, yeah. Okay, so all right, so what I'm getting from another care coordinator, it's not amendment. Okay, it's an initial, but if you already have level of care back, you need to apply separately for the CFC. Okay, it's just going to go through. We're just ticking the boxes. Okay, all right. I'm sorry if that was very confusing. If you have case-specific questions on that, feel free to give us a call. That's the best I can tell you. And mostly, I mean, whenever you're ready, Kara, but mostly it's these ones that were caught in this transition time from you turned the application in, say, in the first or so of September or late August, and we had CFC spin up in October, which is right about the time maybe we're getting level of care determined. It wasn't an option on the application. Now, now you're trying to figure out what to do. Get it, right?
Okay. Okay. Thank you, Sina.
Sure.
Okay. So other questions. The CFC application is with the CFC amendment. CFC application is for application, and CFC amendments are to currently add or change CFC clients' plans. You may have people who are transitioning, like Sina said, so they're for separate reasons, but both for CFC, of course. CFC PCS clients have amendments done by the care coordinator as well. That is true. Okay. So let's go back to our FAQs. I think it might help with some of these basic questions here. Are personal care services going away? No. If a person does not meet a facility level of care, they can still receive PCS. If they do meet a facility level of care, they can still choose to receive only personal care services and authorized waiver services. They can have both CFC and a waiver. We did talk about this just now. Most people have auto-enrolled into CFC. If they have a PERS or want a PERS, they must have CFC. Of course, services cannot duplicate each other. When people have nothing has changed about Medicaid rules. Okay. If a person has both CFC and a waiver, does the care coordinator get reimbursed for two applications, two support plans? No. Care coordination defaults to the waiver care coordination responsibilities and reimbursement level. The care coordinator does need to follow certain requirements to help the person with their CFC PCS services. How does the care coordinator apply for a new applicant for CFC and the waivers? First, the person would go through ADRC, get the person-centered intake form, then they would apply using the application packet for these particular waivers. The person will have a CAT assessment, which determines nursing facility level of care. They will have a service level authorization chart created for their CFC PCS, which can begin shortly after the services can begin after the service level authorization is created. The CFC PCS services can start. Okay, so that would be all CFC PCS services, including supervision and queuing. Skills building and the PERS would wait until the plan of care come in for the waiver, because they are going on to the plan of care. Service level authorization is the chart that tells what CFC PCS services are authorized for that person. Does the recipient need to wait for the CFC PCS services to start? They have to wait for the approval of the support plan? No, they can start on the date of the service level authorization. The plan is going to be approved for all the waiver services. Those ones can't start on that date. That has to go through plan approval for waiver services, including skills building if requested under CFC, and um, the skills, just the PERS, skills building and PERS. Okay, this section is about IMD, so we'll delve into that. But before we do that, I'll see if I can get a little bit caught up on some of these questions here. Questions about level of care and PCA renewals. We do have an FAQ that will address that. Questions about Harmony. Are PCS admins going to be able to communicate and share info over Harmony on the same client? Answer says, we expect all the applications and plans, amendments, and demographics updates to come from the care coordinator. There's nothing the PCS agency sends directly to SDS regarding the client anymore other than critical incident reports. Okay. The date regarding the level of care and renewals for PCS and CFC, the date of the renewal for PCS CFC is the same due date as the waiver reapplication. Thank you, David. Question says, is ADRC going to refer potential consumers to the PCS resources of the area or just decline assistance? ADRC does a person-centered intake. They don't refer people to services directly. They do make people aware of services that they may qualify for. So if that means that if a person doesn't show indicators that they might meet a facility level of care, then of course they'll get resources to choose PCS, and they would, if they did show indicators to meet nursing facility level of care, that they may meet it, they'll get the same kind of resources. Do PCS agencies have to do CFC? All PCS agencies are currently also qualified as CFC agencies. My best answer is that no, they do not have to do CFC, but they would, by extension and thought pattern, be missing out on providing CFC services if they weren't doing that. Okay. If a client has CFC PCS, will the staffing agency still send in a PCS renewal application annually? No, the care coordinator will do it. That comes in on the application for the waiver and CFC together. Okay, meaning one application for both, for either of those, I guess is a better way to put it. Okay, let's put let's talk about IMD. Okay, so how is IMD level of care determined? Through a partnership with Qualys. So we're currently working on the partnership with Qualys for that assessment. The person would have a level of care assessment through Qualys. This is a feature of our CFC option that is the same in all states. So people will have the ability to come into that choice for care through IMD level of care. All right. Can a care coordinator apply for CFC for someone who may meet it? Yes. The applicant must be between age 6 and 21 or over 65, have active Medicaid. They need to have a PCI intake form completed with the ADRC. They need to have a diagnosis from a psychiatrist or a mental health professional. They need to show some indicators of IMD level of care, and we'll show what that is, or at least the beginning of thought about what that is. Okay. So this comes right from the regulation. What is IMD level of care? It's very specific, and it really is focused on institutional facility for a person who experiences behavioral health diagnosis or mental disease, as what IMD stands for. The person needs care in an institution. providing psychiatric services for somebody under 21 or over 65. The person must have a mental illness or severe emotional disturbance that has been diagnosed by the professional, the qualified professional. They are likely to cause serious harm to others, to self and others, or is gravely disabled and has persisted 6 months and expected to persist for a year or longer, this condition. Without appropriate intervention in the home and community, they require psychiatric hospitalization as documented by a mental health professional. So this is very specific. The person has to have this documentation that they would be hospitalized, but for the assistance of services. Definitions. These are new words for many of us, new concepts. Gravely disabled, that the person, because of a mental illness, is in danger of physical harm arising from complete neglect of basic needs for food, clothing, shelter, or personal safety. As to render serious accident, illness, or death highly probable if care by another is not taken, or will if not treated. Means that the person will suffer or continue to suffer severe and abnormal mental, emotional, or physical distress, and the distress is associated with significant impairment of judgment, reason, or behavior, which causes a substantial deterioration of their ability to function independently. Okay. Advanced Alzheimer's does not constitute IMD status in and of itself, to the best of my knowledge here. There is a little bit of a definition here for that. They have to have a diagnosis from their psychiatrist to, as stated in the previous slide, that shows these things. Okay. Question says, so recipients 22 to 64 in this circumstance are referred to other services. What resources are available for them? Behavioral health. Behavioral health has its own waivers and has its own programs that SDS does not govern. Okay, so behavioral health has its treatment programs and treatment professionals under a whole nother regulation construct. So people who are age 22 to 64 are served through behavioral health. Okay, so likely to cause serious harm means that a person who poses a substantial risk of bodily harm to themselves, as shown by recent behavior causing, attempting, or threatening it. They pose a substantial risk of harm to others, as shown by recent behavior causing, attempting, or threatening, likely in the near future to cause physical injury, abuse, or substantial property damage to another person, or manifest the current intent to carry out plans of serious harm to themselves or others. Okay, so this is where, the person has a plan to do it. Okay, they may say that they want to do something or say they feel like doing something, but saying that you feel like doing it is different than saying, well, I want to do this and I have a plan to do this that looks like this, that, and the other thing. I know when to do it. I know how to do it. And mental illness, organic, mental, or emotional impairment that has substantial adverse effects on the person's ability to exercise conscious control of their actions or to perceive reality or to reason or understand. Okay, here it says intellectual disability, developmental disability, or both, epilepsy, drug addiction, and alcoholism do not per se constitute mental illness. So they're not part of mental illness, although a person may have any one of those and also have a mental illness. This is coming right from our statutes. Okay. What does CFC do for a person with IMD level of care? A person will have a CFC only plan. The reason why they will not also have a waiver is because IMD level of care doesn't bring a person into the home and community-based waiver. So this is a certain special category. It's not going to be that many people, we don't think. We're not sure, but right, they're not going to also have a waiver. If they have a waiver as well and a behavioral health disorders, and that's possible, okay, but that's different. This is somebody coming into CFC just for this under those age categories, okay? The person would also have a CAT assessment to tell their services they might get in CFC. They may have some of the PCS services. They may have a PERS. They may have skills building. They will have a care coordinator providing targeted case management for the CFC plan. A person may have behavioral health interventions as well, something that is not included in CFC. This is just there to help people who may be living in the community and could benefit from CFC care, who are in those age categories. People have these this kind of level of need. It's quite likely that they'll have other treatment programs that are not CFC at all. Behavioral health, they'll have treatment programs that are not waiver at all. They'll be behavioral health. Question says, what category would someone with behavioral issues coming from TBI be part of? Not from this one. So a person could always apply if a person needs hands-on help with ADLs or IADLs, or other services that are available under CFC and would meet nursing facility level of care. They could apply for CFC or waiver program. If that person received that injury before age 22, they could apply for ISW or even IDD. So it's kind of different. It's not only for TBI specifically only. Okay, it really depends on the level of care of the person. Sometimes people with the TBI don't achieve nursing facility level of care. Sometimes they do. Okay. So other FAQs. How does the care coordinator apply for CFC on behalf of a person who currently has only ISW or IDD? That person will have a CAT assessment. The care coordinator will apply using the application form, the UNIO 4 application. Then the person will have a CAT assessment and will receive the service level authorization chart that tells the services they could get under CFC. Okay. The ADRC person-centered intake form is not required if a person already has a waiver. This is just a packet list for applying for CFC for someone who already has a waiver. Okay, an ISW or IDD. How does the care coordinator apply for CFC for somebody who already has the ALI, APDD, or CCMC waiver? They don't have to go back to the ADRC to get the PCI, but they would be a new applicant for CFC. So here's the packet list that would be required for a new applicant for CFC. Okay. My client has had an ICAP assessment and meets the level of care for the waiver. Would the client also need to have a CAT for CFC? Short answer is yes. That shows that will show the services that they would get under CFC, PCS. If they wanted to have a personal emergency response system, they would have to have CFC. Okay. We already kind of answered these questions before. Can a recipient be eligible for CFC under 300% categories? No, just a Medicaid recipient can apply for the waiver program that fits their needs. They could apply for CFC after approved for the waiver. The recipient cannot be eligible for only CFC under the 300% category. The PCS agency does sign the amendment. The newest form, CFC 01 amendment, includes a signature line area. If you've used an old version, ask the person to sign, ask the PCS agency admin to sign below your signature. You don't have to go back and fill out a whole new form just for that in our transitional time here. We prefer, of course, that you always use the forms that are up on the approved program forms site. Okay. Does the care coordinator send the amendment to the nursing facility level of care email as if it's a regular amendment, or do we send it to the PCA email? Send it to the nursing facility level of care email as shown. All right, a couple questions here. Okay, who do we contact if we, the care coordinators, are not receiving service level authorizations? Contact Rodney George or David Chadwick. We need to know which consumers. It also depends on if the service level authorization was just sent out or if you're just waiting on a renewal. Okay, the question says a recipient has a personal emergency response system. They only have the IDD waiver. How do they add to their waiver? You would use the CFC 01 amendment form to add the personal emergency response system. Question says, is chore, meals, and respite allowed under CFC, or would CFC and waiver be applied for? Chore, meals, and respite are not part of CFC. The person needs to have a waiver. Okay, so they could have a waiver and CFC if they meet level of care for the waiver. Okay. This question here was about the dates of alignment. How will current waiver support plans and CFC SLA dates, service level authorization dates align? Recipients that were auto-enrolled in CFC now have service level authorizations ending before the current support plan. How is this handled? Current and future waiver recipients enrolled in CFC. Okay, all of the PCS services are authorized until the end date of the support plan. This way they'll automatically align going forward. CFC only, since it's a new option, start date of the plan is the date of the service level authorization chart for only CFC, just a CFC client, nothing else. Okay. Current IDD or ISW waiver recipients with CFC, the plan end date is adjusted to match the waiver plan of care end date. Support plan, I should say. They will align going forward from that. Current CFC recipients invited to apply for IDD or ISW. The person is drawn from the registry. The end date of the CFC plan will be adjusted to align with the support plan. So the CFC, including the PCS services, will always be the same as the support plan. We're getting them in alignment. Questions say, why plan and not ICAP? That is just because it's regarding the CFC PCS services. The ICAP is level of care for the waiver. They meet that. They continue to meet that. Their personal care services through CFC, all the CFC services through CFC, if they have that in addition to their waiver, will just be in that one plan, one support plan. I don't mean to be confusing. Okay, for this here, it looks like it might be confusing. The idea here is that if a person has CFC and a waiver, their services under CFC, be they PCS or the others like skills building or whatever, it's not a good example because it only lasts for 3 months, but those service level authorizations are going to match their support plan. That's all it is. Doesn't go by any other thing. We have transitional things going on right now because of the newness of it, but anything they get under CFC is going to be the same dates as the support plan. They're going to be authorized the same dates as the support plan. It might take time for it to catch up. Okay. Sounds like requesting CFC is similar to requesting waiver services from vendors in the waiver support plans. Is that true? Yes. The care coordinator requests, renews, and requests changes in CFC services on the recipient's behalf, a lot like waiver vendors in the waiver support plan. Okay, once a CFC client utilizes their 90-day skill building, meaning 3 months, will they remain a CFC PCS client or will they go back to being only PCS? They will remain a CFC PCS client. They just won't be able to request and get the skills building anymore. It is simply a service that the person can request if they're a CFC client. They can have 3 months of skills building as authorized in a plan of care, support plan. It can amount to no more than 3% of their total CFC PCS time authorized, and 3 continuous months they will pursue a skill and that they identify in an ADL or IADL, not other things, just ADLs and IADLs. And they will remain a CFC client. They just will have exhausted that particular service. Question says, so if the PCA plan of care had a renewal date of January, but the level of care CFC renewal date is not until June, they will not require a PCS renewal in January. It will extend to the level of care date of June. Correct. They're being realigned to be the same, extended to be the same. Thank you. Okay. Who provides CFC services? An agency that's certified and enrolled to provide CFC PCS, and all of our PCS agencies can provide CFC PCS. It's not a new provider type. It's not a new care coordinator type. Nothing new. It's a selection of services. If a person did not opt out of CFC, will they have the opportunity to opt out in the future, or will they either have to keep CFC or reapply for PCS? They will have to keep CFC or reapply for PCS if they cancel CFC. If they end CFC, they're ending everything, including the PCS services in it. They will have to reapply for PCS only. They can't just revert back to PCS automatically or opting, whatever. Because our PCS agencies are currently working in harmony, there are some items that if you have the ability and the ability, it's kind of a dumb way to put it, but if you want to ask a PCS agency to submit and the PCS agency agrees to do that, it's okay to submit it through Harmony via the PCS agency. However, the care coordinator is ultimately responsible for doing it. So we're asking you to submit it through DSM. But if you are working with any of these 3 documents and you have completed them, you certainly can work with the PCS agency administrator who can help you by submitting them. Okay. So let's look at processes and forms for CFC clients that a care coordinator would do. We have a couple of sample forms to give you. I'm going to let's see, what time is it here? I'll give us like a 5-minute break here so I can load up my new forms and things like that. We've been at it for a while. I'll get to another presentation. I'm going to take out all of the downloads that are in there now. So if you haven't downloaded them, go ahead and do that now. I'll give you about like a minute to do it. If you get them by email anyway. So if you don't get them, don't panic. We'll get them to you. We'll take a 5-minute break and we'll go on to our sample forms and our cost sheets. Okay. All right. Thanks, everybody. 5 minutes, we'll be back. Hi, everybody. All right, so let's get back to work. Let's talk about the processes and forms for care coordinators um, for their CFC clients. Some wonderful answers have come in to our questions. Um, the biggest one here, I think we answered all of them. We're just kind of putting them in writing. We certainly have answered them verbally, and I've read out the answers to the ones that we didn't know, but um, it says uh, if a person has a new waiver, okay, say they already had personal care services, then they applied for a waiver and they got a waiver. Are they automatically enrolled in CFC? The answer to that is no. The person needs to apply for CFC to be enrolled in CFC. They would certainly have the level of care, so they could apply for CFC if they wanted the service of personal emergency response system and or skills building. They would have to and or supervision and queuing, because PCS does not cover that, PCS only. They would have to apply for CFC. Okay, a person doesn't get automatically enrolled if they're, a new waiver and they already had PCS. That was for people who already had PCS and an existing waiver. Okay. All right, question says, if a person's IDD renewal plan is being submitted in December, do I have to do an amendment for CFC until the renewal date, or can the CFC start with the renewal? If the person wants to add CFC, do an amendment at any time. Their PCS services or anything authorized on their service level authorization chart can start as soon as the service level authorization chart is made. That's my best way of thinking through that one. Question was, they were auto-enrolled in CFC. Okay. Then your question is different to me. They already have CFC, then you just continue to their their CFC services are going to be authorized through their plan of care. The same as it's going to have the same, their service level authorization is going to have the same dates as their plan of care. And you're going to request the services to come on the renewal, for the renewal. There was a question about transfer of services, like when a person wants a different provider. Okay. They want a different provider. Transfer of PCS services can happen on the date requested by the client, but respite and chore transfer is held and awaited for approval from an amendment from the care coordinator. Though respite and chore are currently waiver services, they're not CFC services, so nothing has changed about that. PCS services, whether it's CFC or just PCS, are still PCS services. Nothing has changed about that. The transfer of any services from one provider to another under CFC nothing changes. It doesn't affect respite and chore because they're not CFC services. Okay. Cost sheet handouts. Okay, I did put a couple of example cost sheets in there. If you can't download them, just try. If you can't download them, don't worry about it. We're going to email them to you anyway. They take up quite a bit of room in the handouts there. So go ahead and grab the 3 that are there. Then I'll get rid of them and I'll put in the rest. If you can't get those Excels to open, don't sweat it. I'll show them to you and I will get them to you in an email. They do take up quite a bit of room in the webinar. So do your best, and don't worry about it if it's not working. Okay, we'll get it to you. All right. All right, so processes and forms for CFC clients for care coordinators to do. CFC 01, the amendment to the service plan. I have an example up in your handouts there. We'll take a look at that one. This is just a CFC amendment for a personal emergency response system. Okay, so thank you, David, for making these examples. These are pretty good. They're great. I really appreciate it. Was something for you to see that helps you understand. I just opened it. Okay. Um, so here we have a adding a PERS. Um, when it says state plan services, did get a lot of questions about that. It just means what is covered under our state plan, which is CFC and PCS services. All states have a plan for their Medicaid services, and every state has to make a state plan for the Medicaid services. So some of them we talk about them that way. It just means CFC. Okay. Um, the amendment is to add a CFC service. So that means that it's this and not like somebody else or something else. Okay. They want to change in their services. All right. They'd like to add PE. They add a PERS through CFC and have the most recent assessment reviewed for PCS services. So where it says 4 months of personal emergency response system, that's not a literal thing that you have to copy and do. Okay, we don't want you to copy any of these things. It's just providing you an example. This is to show that we need specifically to know how many months of a personal emergency response system they want to add. Where are they at until the end of their plan? Okay. Make sure to include the installation and make sure to include the cost sheet. Okay. The person may or may not need a new assessment. Okay, it's difficult to, back analyze every situation, but just know that sometimes people might get a new assessment. Okay, so for personal emergency response system, it doesn't, the middle part here, it's not a PCS service. Okay, so we're not doing this chart here that's just about the hands-on care. Okay, it's something else. It's a PERS, it's an item. Okay, and then in the last box, it says for each activity listed, describe how the requested adjustments to frequency, scope, and length are necessary because of their material change. All right, so here it says they were unable to access the PCA program or personal emergency response system for whatever reason. Like if a person moved out of their assisted living home back to their own home, they didn't have a PERS before, or they have like a health related reason that they need one now. Why are they requesting PERS? If they were going to add skills building, why are they requesting that? Okay, explain why. That's all it means here is explain why. John Doe would like to add these services as he may now be eligible, or they may now be eligible, and this would improve his health and safety or whatever. Okay. Again, it's not a copy paste situation. We're just trying to say what to do in this box. Okay. So if we scroll down, we attach documentation that supports their adjustments. Attach Uni 14B CFC cost overview sheet for requests that include personal emergency response and or skills building. Person signs it. If there's a witness, they sign it. Care coordinator signs it. PCS admin signs it. Okay. So let's look at the cost sheet. It's funny looking right now, but let's look at it like this. This is the example if a person is requesting a PERS. It also has everything listed here that's a CFC only service, if you will. PERS, one per month. How many? Okay, so required areas here. How many units do they need? Okay, how many months of PERS will they need? How many installations will they need? And here's the other cost sheet. Don't worry. This is if the person was going to request skills building. The person could, of course, request both PERS and skills building on one sheet. We just have two sheets here that are separate. We're asking you to put the units. Again, it's not any more than 3% of the total time authorized in their service level authorization. So enter total PCS weekly hours here if you're requesting skills. So find out how many PCS weekly hours they have and enter it in that box if they're requesting skills building. Question says, hang on. All right. If a person has waiver and PCS services now and decides to stop home delivered meals, does the CC now complete the new process to submit the changes? Also, does the care coordinator do the PCS amendment? Answer is meals are not a CFC service at all. You would need to complete a waiver amendment to discontinue that. Include the updated waiver services overview cost sheet. We're just talking about community first choice here, not waiver. That's their meals are not a CFC service at all. Okay. If they also have CFC, it covers their personal care services. If they have a personal emergency response system, and then if they want to request skills building or supervision and queuing to be added later, that's okay, but not meals. Okay. Everything else is still waiver. They have both. Okay. What kind of documentation would someone need to request a personal emergency response system? They need a prescription for it. You can go back to your regulations about personal emergency response system, which was formerly a waiver service, now is just CFC. Nothing has changed about that. They need a prescription for that. Do we include the same cost sheet if the client already has a personal emergency response system with their renewal service plan? Yes. Send in both this cost sheet and the waiver cost sheet upon renewal. Their prescription would be from their doctor, yes, for PERS. Okay. They have a dual waiver and CFC. Does the other cost sheet have these areas on it, or do we have to do two? You have to do two. Okay. And send this all to the NFLOC DSM, yes, nursing facility level of care. Question says, wouldn't the care coordinator make the CFC amendment to reduce IADL meals? They could request that on an amendment to their CFC PCS services. Yes, they could. For a reduction of that, they could do that. Okay, I'm going to freeze on that and close that current tab right here. Okay. So I'm going to delete the handouts here to make room for others. And I'm going to put in, and it might not like me at all here. Sometimes in the webinar, it won't let me put in any more. I think I'm just going to end up having to show you the rest of these because it's, unless it catches up a little, it may not have any of its own storage for any more, but that's okay. We'll get it to you. All right, we can show them. Other questions coming in. Where's the area on the cost sheet to discontinue PCS? The cost sheet is not required to reduce PCS services. We need the CFC PCS amendment form to include that information. If they're going into an ALH, you would discontinue PCS, yes. You would do an amendment form to discontinue that. What do we do about the recent ones we sent in with just one cost sheet? The person only has PCS and regular waiver, so do we now just send in this additional one after the fact? No. If you've already turned in, prior to October 1 and you haven't gotten a requirement to turn in any more, my best answer is that you wouldn't go back and redo work that you already did. Okay? This is going into the future should there be changes. Okay? A care coordinator can amend the waiver support plan to add supervision and queuing or increase PCS CFC authorized hours using that amendment form. So I have a supervision and queuing example here. If the person wanted to add supervision and queuing to their CFC services, okay. In here, I would put request the most recent assessment to be reviewed for supervision and queuing. That means that we'll go back to their most recent assessment that they had for PCS before they were enrolled in CFC. And we would be requesting that to be reviewed for the ability to add supervision and queuing. And that requires a certain score in their behavior and cognition part of their CAT. Okay, so we may or may not do a new assessment for that. It really depends on the person. It could possibly result in a change to approved personal care services, including reduction or termination should there be a new assessment happen for that person. And there's all kinds of reasons why that would happen that are past what we can go through here. But it always is the case for if a person has a new assessment, then they could be changed. Something that they might get more services. Could be that too. Okay. List how the requested adjustments are necessary because of material change. Because of change of state plan benefits, this just means that the service wasn't previously available. The person would like to add it, and they want their CAT reviewed for the possibility of that to add supervision and queuing. And then your signatures are required. Okay, so that is just an example of CFC supervision and queuing amendment. PERS and skills we kind of already went over, and I'll just show you let's see here. Let me find another one to show you. So we did supervision and queuing. Let's look at one that just increases personal care services within CFC. So we make an amendment to their service plan because the person has a different medical condition happening. They need more help with their personal care services. They're a CFC client. They are care coordinators taking care of their CFC and or waiver or just CFC alone services. They need more. Something has happened. Okay, so important details. The consumer reports he fell and broke his leg. He needs help until it heals properly. Please consider the increase in frequency and/or level of assistance. So here is where you would fill out the chart. They currently have PCS services, but they need more. And to this point, frequency, scope, times per day, times per week, and how long. Okay. I know it just says things here. It just means that you write something. Okay. Again, we don't intend these to be, something that you copy and paste. We're just being, we're just trying to show you that you need to write here. Okay. So they have a broken leg. They can't do something. They need help with something specific. Be specific. The doctor explains that they need to have more care at home because of their inability to move about. They have a really big cast on their leg. You need to show what the evidence is that the person needs this because of their material change. Okay, we're not putting a lot of wording there. It just is intended to show you to be specific there. Okay. right? And then at the bottom, of course, we have our signatures and dates. Okay. All right. Yes, it's true. If a person is applying for CFC, they need to start with the application if they don't currently have it. Recent plans don't need another overview sheet. Sorry. I'm catching up here. And this was the one that was, I think our screens weren't catching up, or maybe mine weren't. This was just the example of the chart for the PCS hands-on care to increase that for a person who broke their leg as the example. And then the narrative here, of course, we don't want you to write just something, okay? We need you to, like it says here, this is not for copy and paste. This is to tell you that you need to be specific about why the person needs the increase in their hands-on care for PCS. CFC for a brand new applicant must go through the ADRC, yes, for an initial. If they already have a waiver, if they currently have a waiver already, they do not have to go back to the ADRC. Overview sheets are required, yes, for renewal plans of care, support plans, for waiver, ALI, and CFC, yes. Some of your combo clients will have 2 cost sheets for the services that are on, for the CFC services that are not the CFC PCS ones. So this is just showing your lists here to apply for ALI, APDD, or CCMC with CFC, your document list. Some of them are only for the initial application, okay, like ADRC, person-centered intake form, okay. Applying for an IDD or ISW waiver with CFC services. Question says, if they just want PCA, do they go through the ADRC? No. A person who just is applying for PCA does not have to go through the ADRC. Okay, question says, we do an overview for waiver services, yes, like respite and meals. For CFC overview, if they only have PCA services and not skills building or a PERS, personal emergency response system, then you do not have to fill in the other cost sheet, the Uni 14B. That is only for if they're requesting those services that are unique to CFC. Okay, the CFC PCS is not a separate cost sheet. Okay, support plan packet list for a CFC only client. Okay, that would be somebody who doesn't have a waiver as well. Your support plan packet for ALI, APDD, or CCMC with CFC services. This articulates the 2 cost sheet idea. Uni 14B if requesting PERS or skills. Uni 14 for the waiver services. And support plan for IDD or ISW with CFC. Okay, same kind of idea. Requesting CFC while traveling, CFC 02 We can jump out on the web and take a look at that quickly. Requesting transfer of CFC PCS agency or change the service model. Okay, that would be from consumer directed to agency based. We're more so just presenting this as the list of forms that are with a care coordinator now, when the person's a combo client essentially, or just CFC, if they have these needs. If the person is going to request passive range of motion, then there's a detail there to fill out that form during CFC PCS, the hands-on care part. Okay, the care coordinator would take care of that. To add a renewal request for supervision of eating during CFC PCS. Now I realize that a lot of our care coordinators don't have they need enhanced awareness and education on these particular items here. Okay, like what are the PCS services all about that I might have to take care of under CFC? Okay, so we're putting those things together. We're of course putting together more training for you. Okay. But these are currently the responsibility of the care coordinator. We can look at the forms. Regulations tell a lot. I don't know that we have a ton of time to go over all those. We can take as long as we want really here. I think this goes until 3:30, I think. But so we can certainly explore some of these, but again, it's not the be all and end all of training that you would have. We're just kind of unpacking the box. Okay. So to add a renewal request for supervision of eating, these are special services that a person can get under PCS, basically, CFC PCS, right? If they need a person to go with them, they're traveling and they need a personal care, assistance while traveling, and they're a CFC client, it is possible to request that ahead of time to be authorized to occur while traveling. Now, PCS services don't get increased just because they're traveling. We just know that they're being delivered to that person for specific reasons while traveling within the United States. It's not available when they're traveling to a foreign place. They can change agencies or change the service model, agency-based or consumer-directed, through a notice of transfer form. They can request passive range of motion during their care, their PCA care, if they're a CFC client, CFC PCS. It needs to be a form filled out by the prescriber of passive range of motion. Now, if you think about it, a person has to experience a certain medical conditions where they're at risk for contractures of their limbs, their extremities, because of a disability. And their doctor has to say in a prescription, not literally has to say, but the prescription will be there because the person must have certain passive range of motion exercises that are safe to do by a person who's unskilled, meaning not a medical professional or a licensed care person. They're a PCA worker, and they have to happen at home because that is where this happens. It's not like therapy that they do in a therapy place. It's ongoing care for that specific reason. So the prescriber will do that. They will request it. They'll fill it out. They'll prescribe it. And the prescriber will make a smaller plan of care for that passive range of motion that educates the worker on how to do it. And there will be medical documentation that supports the prescriber's recommendation, like a diagnosis, treatment plans, and other things like that. So that is how a person could potentially receive passive range of motion during CFC, PCS care at home. Okay. Okay. Other questions here? Let's go back a little bit. The PERS prescription is only needed for initial support plans, or is a new one needed every year? It is required every year. A PERS prescription is required every year. The request for travel includes regular PCS hours and skills building. It can, but again, that doesn't mean that anything has changed about the levels or the amounts. So they're going to use up their skills building to pursue their own independence or enhancement of an ADL or IADL while they're in another place of the US. Yes, but it's all going to count towards that 3 months total. And they're not authorized additional services just because they're traveling. When traveling, does the PCS continue to get paid for duties? Yes, that is why the notification through the request while traveling is done, so that the provider of PCS is ready to make that happen. And the person is continued to be provided, and they have to do documentation. They have to be responsible under all of the PCS and CFC PCS regs. Yes. It doesn't pay for the individual worker's travel costs. No, it only pays for what is delivered according to the approved service level authorization and plan. Okay, if a waiver client doesn't have a PERS but does have PCA services that do not include supervision and he doesn't want skill building, is he on the CFC waiver or not? CFC is not a waiver. CFC is an option. In this example, he is on CFC because CFC is the only thing that contains PERS. I have to have CFC if I have a PERS. Travel form is always prior authorized. Okay, CFC PCS travel form submitted prior to their travel begin date or provided after. It needs to be done before and prior authorized. That means that we have to submit the form, it has to be prior authorized, and then the travel occurs and the service is done and documented and billed. So when a client travels, do we do CFC 02 and an amendment for the waiver? If the person is requesting the CFC services while traveling, we do the CFC 02. If the person is requesting waiver services while traveling, or while out of their community is the way it says for waivers, then we follow the procedure for requesting waiver services while out of the community. Your question about if the client doesn't have a PERS but does have PCA, if the person was part of the population that was automatically enrolled, they had both a waiver and PCA as of October 1 and they did not opt out, then yes, they have CFC. A person has both PCS and DAHAB, so 2 documents. My best answer is yes. Yes. Those are all required. Yeah. Good question, though. It's got me thinking. Okay. Supervision of eating is a service that's available under CFC PCS. Again, this goes back to the hands-on care for just PCS. To get supervision of eating, I need to have a medical condition that tells that while I eat, I'm at risk for many things. So I need somebody to supervise me during eating. I'm able to eat, but I need to have somebody there to supervise me. So because of that, we must have a swallow study conducted not earlier than 1 year prior to application or reapplication, which tells the need for supervision of eating. It's kind of like passive range of motion. I have to have a medical condition that says that I need to have a PCA worker there during that time so that they can watch me eat and I am safe. So there needs to be a swallow study. And then the amendment, along with a swallow study, can add or renew supervision of eating. Supervision of eating does not get renewed automatically. It is a yearly renewal, an annual renewal. So there must be an annual swallow study in order to continue to authorize it. Same thing for passive range of motion. I know it doesn't say that specifically, but it needs to be current for their current year. They are going to renew, they're going to add, but when they renew, it doesn't automatically get renewed. The documentation has to come in that that's needed. Again, if you think it through, the person's living with a disability, they're at home, they need passive range of motion because they risk further contractions to their extremities. Doctors determine this, written out a little plan for the worker to follow. It's safe for them to do. They know how to do it. It's prescribed. It could potentially be approved as a reimbursable PCS service through CFC. Because today we're just talking about CFC, it's also reimbursable just through PCS. So another reg set, but okay. Information and resources about how to select and manage staff for CFC PCS. Your PCA and you, I did put that into the handout section earlier. Again, it would just be a booklet that you review with your individual who wishes to receive this information. I'm showing it right now. It is made for people we serve we're assuming that somebody would be starting at the beginning, maybe interviewing and hiring staff. We realize that not everybody does that. It is written kind of from the very, very beginning. A person can simply take the information from this document and use what works for them. This is open to all people, who might want to know more about finding a worker and directing a worker, things to do, things to know about. It's intended to be quite person-centered, from the person's point of view, knowing about your support plan, who could be a PCA, who could be the person who could help you. I don't want to read it out to everybody, but just some of the topics, how might I find someone who could work for me? Again, the agency is the employer of record. We make that clear here. How might I meet somebody new to me if it's not a family, or how do I stay safe with that? Talk on the phone, interview somebody, give them information, stay generic, questions to ask people who might be new to you about your care, meeting somebody, ask about the person's expectations and your expectations, things that don't have to do with the services themselves, but things that people experience when they're working at home. What about smoking? Where should the person park? What about other people who live in the home? What about the phone and Wi-Fi? What about pets? What about private places in the home? What about private times? Because it's a very, personal service. They're in the home. Again, we're trying to be person-centered to help people think through ways that they could be taking charge of their own, care. And establishing good boundaries and welcoming people into the home who can do the work. And trying to be clear. Work schedule, medication, where to park, how to enter and exit, emergency information, safety practices. We get a lot of questions about these things. Mobility and medical equipment. If I'm working in the kitchen, what do I do? How do I want things stored? How do I use appliances? The person can tell them that or show them that. Which cleaning products are used? In the bedroom, where do I find items? How are they stored? What are the expectations? In the bathroom, if I'm helping somebody, what do I need to tell my care worker to know? If there's a utility room or a laundry, if there's buckets and mops and things like that, what do I want done? How do we handle food breaks or personal breaks when the PCA is working, if there are? What about smoking? I get a lot of questions about that. Smoke-free workplace. Now the home's the workplace. What do we do? What do we expect? Is there a place for if the person takes a smoke break, how do they get rid of the trash? What about, the person, can we agree to not smoke while we're working here at the house? That type of thing. Personal cell phone use. All these things are things that will make uncomfortable conversations for many people unless you talk about it ahead of time. Pets. Outside of service dogs, what's going on with pets? Are they comfortable? Do they need to know about the pets? They need to meet the pets in order to be comfortable and safe with each other. What's off limits? Everybody's home has private areas, and what people shouldn't have to change their whole way of life just because staff are there, and the other way around, I guess. How can I help my PCA be successful? What to do if there's a problem? How to get help for a small problem, maybe work it out with the PCA. How to get help if there's a big problem. If you have a really big problem, that would be like an emergency where you need help right away. Okay. And then just some notes, who to contact. You could certainly, put in a care coordinator there too. I know it says PCA, it's focused on that, but certainly a care coordinator can sign this with the person and review with the person. Again, that is available to anybody. Even if you're not doing CFC or you just want a copy of it, I'd be happy to send it out to anybody. Okay, I printed and handed this out, especially useful when talking about the services. It's helped to bring up topics they face. Well, how cool is that? I'm so happy to know that you could use that. It has helped identifying support people in their lives versus paid and versus unpaid. Recipients get upset if taking breaks during PCA time. They wanted to know, how are their staff allowed to take breaks to smoke? That's a reasonable question if somebody's working in your home. We really tried to put the mind to the home care receiving. What would that be? Where do we find it on the website? It's not there yet. All these things are new. So we're working, there's so many new things to put up. Shouldn't this include the provider agency too? Yes, it does have the provider agency in it. It has a little paragraph that says that the agency is the one that employs your staff. They have to pass the background check. They have to have training. You are welcome to use this. I mean, as a care coordinator, we should share if the person has PCS or CFC. And even if they don't, you can share this with the person. Okay. You can see all the updated forms on the approved forms page. We can explore some of those special services there, like the travel request and things like that in just a minute or two here. At the end, we have our last update here on our document. When filling out CFC 01, add a personal emergency response system, use the text box to describe it rather than the CFC, hands-on care grid. It really isn't that. It's not a PCS service. It's not a CFC PCS service. Okay, we gave you an example of that too, so it should be easy to remember. So let's go to the forms page and we'll bring some of those forms up here. Okay, so the approved programs forms page has everything under the sun here that it's in development as well. So if you get stuck on anything, always ask. Okay. Always keep your bookmarks updated. If you go to an old page through a bookmark that you kept for a long time without going out and using a search engine to get a new copy of our website, you may not see some of these new forms. So you want to, periodically go out and search for us. You can just go to Google or whatever is your favorite, and you can put in Senior and Disability Services Alaska, and it'll bring you to our webpage. You can get a new copy of the webpage that way. Many folks are keeping bookmarks forever just because, like me, I didn't know that it would go to an old copy of the page, the one that was made when you had your bookmark. Okay, so your amendment is here. The application for CFC personal care services while traveling is here. It does give you some clues as to the um, it does give you some clues as to the nature of while traveling. Um, Additional time, they up to 30 days annually. Again, that has to do with DPA rules about being an Alaska resident because you're getting Alaska Medicaid. Um, you need to be in the state for a certain period of time, and if you're gone longer than that, then you have to make sure that your Alaska Medicaid remains valid, not just PCS, but Medicaid itself. That's why it says that there. Okay. It does give you the check boxes for, I'm going to open it with something different here because it's funky looking. A couple people said they lost audio. I'm just going to write, if you lost audio, you, hang in. Sorry, I have to write it because they can't hear me. So I'm just writing, if you lost audio, please exit the webinar and use the link to rejoin. It's the easiest way to do it. I know it sounds weird, but it's true. Okay, so you can request PCS CFC or CFC PCS while traveling by filling out this form, attaching documentation of medical necessity that the person needs this care while traveling. The purpose of the travel is medical necessity, sorry. The purpose of the travel is educational. The purpose of the travel is vacation. All right. Have they submitted and authorized a services while traveling application this year? If yes, what were the dates? Are they requesting the same services as they currently receive? If no, then if no services are needed, then while traveling, the request may be approved as submitted. Okay, service authorization may be adjusted to remove it. So if they're traveling and they're not requesting services, then their services may be adjusted to remove units that occurred while they were traveling. All right, state while they do need the services, why they do need the services, and why their need for assistance with ADLs, IADLs, and other covered services can only be met by a personal care assistant. Do they anticipate an absence of more than 30 days? If no, just go to the signatures. If yes, answer the following, because it's a medical necessity, and attach documentation about that. If it's an educational opportunity, attach documentation about that educational opportunity. And it is required that the person is absent more than 30 days. They don't have any other options within Alaska for that opportunity. And your signatures. Okay. So let me go back to my website here. I lost it. We'll get that back. Questions here. Question says, am I understanding correctly that if a waiver client needs to travel out of their community for a medical reason and they need the PCS services but no other services, the care coordinator is now filling out the travel request? Sort of. The person has to have CFC. If they have CFC and they're requesting personal care services within that CFC while they're traveling, then yes, the care coordinator fills it out. Okay? Care coordinator for CFC, whether they have a waiver or not. All right, more CFC forms. Notification of transfer. This is when the person wants to change the kind of PCS they're getting under CFC. Either they get consumer directed or agency based, or they're getting a different agency to do their PCS care. All right, so agency transfer or model type transfer, current agency to the new, provider numbers. All right, the CFC modifier is going to be referring to, I'm assuming, consumer directed or agency based. We'll have more trainings about these things because it's kind of delving into it a little bit more. So it says, will a list of questions and answers be published? We will. We'll add to our FAQs and make it available online. We'll send you the one that we gave out with our webinar in an email, along with the others that I couldn't get to upload. There's a few others that you can get a copy of that we'll put in for you. Okay. So that would be transferring from one agency to another, and or different, to use this form for an agency transfer or a service model type transfer. Consumer directed is just where the person refers staff to be hired at the agency to be their PCA, and by person I mean CFC recipient. Okay, so most of the work is consumer directed. There's not very much agency-based PCS that's done, or CFC PCS, same thing. Okay. Agency-based is when a nurse oversees their PCS or CFC PCS services, their plan. Okay, so that is, there's a little bit of different nuances under which the cares can be done. If the person is directing their own services, they can direct their staff to do things that couldn't be authorized under the supervision of a nurse of a plan. Okay, so the differences between agency-based and consumer-directed are kind of specific, but that's going to have to be for a different training for care coordinators. Okay, so we had that, and then we had the we have a couple of other forms that are also for care coordinators too, but this is kind of just really getting into the more details. Passive range of motion is here. It's not yet under here, and I think that we're kind of getting into alignment the different forms that we want, and we're hoping to be eventually, of course, transitioning these things to Harmony. We're working really hard on Harmony right now, which is why you haven't seen a lot of these forms kind of be separated out. But for passive range of motion, it's still up in the PCA world here. It will give you an idea of what is required. You may not have a lot of people adding this or renewing this that are in the category of CFC people. You know, you may come upon renewals for this. Okay, lacking current training right now, I would say you'd be more than welcome to call or email for guidance. Oh, thank you. It says Rodney George sent out an email with a list of combo clients on 11/14 if anyone's wondering if their client is a combo type. That's great to know or to be reminded of. Thank you. So some of these processes are still in our PCA, list here. And so what else? I think that was it. Notification of transfer. I don't need that one anymore. Go back to that. So again, at the end of this document, it's just a list of practices that are care coordinator practices for your CFC client. Some of them were formerly just PCS and have come to be a care coordinator's responsibility under CFC. And some of them are new because CFC is new, like the amendment, CFC 01. So while traveling, had its own special form. Transfer of agency or model type had its own special form. Passive range of motion, that's the one I was missing. PCA02. Okay, no, I got that one. Sorry. Supervision of eating. Okay, didn't have a separate form. Add a CFC01 with the swallow study results. Okay, we did not get a list from Rodney. How do I contact him? You can email him. Do I direct questions back to Rodney because 2 of my combo clients weren't included on my list? Yes. Let me write his email address for you all. Hang on. Yes, for both. Yes, for both those questions. Okay, so your FAQs have been presented in the little PowerPoint that we had. We reviewed them. We went over quite a few Q&A here. We will provide you with an email that has all of the attachments and all of the materials that we've shared. Okay. I think that my webinar didn't like it very much when I put the Excel spreadsheets in, because then it won't accept any more handouts, but that's okay because we're going to email them to you. We will have a recording placed up on our YouTube site. I'll provide you with a link to the YouTube site that if you want to review it at a later date, or if you have a colleague who couldn't come, you can send them that link and share it. And as we go working together, we'll have more answers and more trainings available to you, particularly around the PCS, the CFC PCS services that are the traditional hands-on care for ADLs and IADLs that we can add to our care coordinator training. So look for a lot of that. We're in development with a lot of new things. But again, we're happy to tell what we know and explore what we don't know and share that when we do discover it. Okay, so this is the conclusion of my presentation. Are there any further questions that you feel weren't addressed before? Go for it. Okay, question says, is there a list of added responsibilities of care coordinators with the addition of CFC? Yes, there is. I'm going to show you where to find that. It's not really a list, it's the conditions of participation. So if we go to regulations and related materials, all right, so if you look at this box up here, you can find care coordination services and LTSS, long-term services and supports, targeted case management, conditions of participation. This document states the requirements for care coordinators. And if we go kind of sort of towards the end of it, it has support plan, recipient and provider contacts. It's got details, so it's all relevant to care coordinators, the whole thing, but it tells you here what the requirements for contacts are. Not that contacts with the person is the only thing that a care coordinator does, but it gives specifics about contacts to the recipient, and they're a little different for the different waiver types. All right, so there's that. As far as the responsibilities of the care coordinator, then the question that you're talking about here, I don't have a separate list other than what I've already provided. I feel like some of these things that we provided earlier might have sufficed for a list like that. This is like the regulatory authority that puts it together, but your list of responsibilities are for practical matters would be at the end of the FAQs. And I'm thinking that I could make a new chart for that. It might help. So yes, there's nuances within the conditions of participation that you want to read. That tells that a care coordinator is responsible for these things because they have a CFC client, they're a care coordinator. The duties of care coordination haven't changed, but for the recipient contacts parts. So to help a person manage and change their services within CFC, you have the same responsibilities as you do for a waiver. So that would be, like if you had a different vendor that they wanted to change vendors of a service for a waiver. If they wanted to change something about the waiver service, it would be the same responsibility for CFC. They needed something while traveling, you would do it for waiver, you do it for CFC. Right? There's just nuances within the PCS services that have become a care coordinator's purview under CFC. Okay, and there's I think it's a question about a list of documents. You will find your list of documents in the FAQs. They're listed out for initial and renewal. Other questions? Okay. I am not seeing a whole lot of questions come in. Your comments are certainly welcome and your concerns are welcome, of course, as always. I am going to say that we can go ahead and close our session. It's just coming up on 3:30 now. We have about 7 minutes left. If you are done and you want to leave the webinar, you're welcome to click out at this time. Thank you so very much for attending with us here today. Look for our follow-up emails and our video and all that good stuff. Give us time. It's going to take time to upload and get that to you. And we'll be, of course, always adding to information for you. Don't forget, there's a great CEH happening tomorrow. Go back to the website, the training website, if you're not in it and you want to be in it. I'll just give a plug to that. The Alzheimer's Resource Agency is going to present Alzheimer's and IDD. So if you had questions about Alzheimer's and working with IDD, people who might experience Alzheimer's and IDD or aging with IDD, well, you better come tomorrow because it's going to be awesome. So go back to our website and get the link and join us. We only have about 25 people. So if you can spend the time, it's a 2-hour webinar, 10 to 12. Go for it. The other information that you need, we're working on adding to our training for you. And look for our follow-up. I'll stay in the session here. I'll turn off the audio, but I'll stay in the session for the next few minutes in case you had additional questions, just to type in. Okay, so our session is concluded. Have a great rest of the day, everybody, and thank you for choosing to spend your time with us here today learning about CFC and all the different things that we all have to know, and we're learning along with you. Goodbye for now.